All right, so let's go over chapter 24. Again, it's amputations, prosthetics, different trainings that we will do, and treatment as well. This is a cool story or movie. It says available on Netflix, but it's not anymore. You guys can look it up. I think it's an older movie, but it gives you a good idea of what life is like for someone with a new amputation. It's a really cool movie. If you want to watch it, feel free and tell me all about it. There's also some videos. This PowerPoint's on eLearn. You guys can look these up. Amputee OT is a OTR that has a transtibial amputation, and that's kind of neat. There is an OT. She works in Princeton, and she has no arms. We know her. Oh, you know her? Oh, how do you know her? We had to watch a video. Oh, you watched the video. Was it the USA Today or something like that video? Yeah, she's big. We have a fieldwork rotation with her too, so she's very cool. But anyway, there's lots of different videos you guys can look up and see how life is like for someone with an amputation. All right, so let's talk about some causes and types of amputations. Prosthetic use and OT intervention are affected by the cause and the type of the amputation, the side and the number of limbs involved, and the person's age and health status. So let's talk about how this is different and how we can approach it differently. If someone was born without a limb versus someone who loses a limb later in life, how does that affect a person differently? Cassidy. Okay. Right. So, like, if someone's born without it, there's not really a training period that would be outside of what a normal training period would be, right? But if someone loses it later in life, there's a retraining aspect to it. What if somebody has a long transradial amputation or a long transhumeral amputation? Do you guys know what those are? Remember from reading this chapter? What's a transradial amputation? Where are they cutting off at? Below the elbow is what transradial means. What about transhumeral? What does that mean? Above the elbow. Below elbow, above elbow. Okay? So if someone has a transradial amputation versus a transhumeral, what does that affect treatment? Does it affect their ability to function? And which one do you think has more function? Because you still have that uniaxial joint in the elbow. Absolutely. What if someone loses a leg at 2 years old, 12 years old, 32, or 72? Jennifer, what's the difference? Okay, why is it different for someone that's 2 versus someone that's 12? What do you mean? They're still learning the function. At age 2? Okay, so why is that different than someone at age 12? Aren't they still kind of learning? Okay, so they're relearning. You're adding in that re-education. Okay, why is it different for someone at 12 than it is 32? Faith? I feel like through 30 years of life with and okay, so it's harder the older that they are. Okay, what about someone versus 32 versus 72? Maggie. Yeah. What would be a common reason that someone 72 years old might have an amputation? Diabetes. That's the most common thing. Either that, or if you work at the VA hospital and you're working with veterans, um, that's another high amputation population. So what if somebody loses 2 digits on their dominant hand versus their non-dominant hand? How is that different, Isaiah?
I don't think it matters which digits, but I guess the main difference is use this one for everything, and you're used to using scissors, whatever, and you have to either relearn how to do it on this hand or the other hand. If you lose this hand, it doesn't really matter.
Okay.
For the one-handed tasks.
So if I came up to you, Allie, and I told you that I want you to start writing all of what's your dominant hand, right? So if I told you you now have to write all of your notes with your left hand, it would be frustrating, right? And now it's not me just telling you, you no longer have a choice because you don't have a right hand anymore. You have to learn how to use it. How frustrating would that be to learn how to do everything with your non-dominant hand? And then throw in that you only have not just your dominant hand, you can't use it, but you have one hand period to do things. Think of how many things that you do with both hands. Simple tasks like getting things out of the oven, you might use two hands for that if it's something heavy. What would be another thing you can think of, ADL, IDL wise, Cassidy? Washing your hair. Would that be really hard to do with one hand? Okay. Okay. So things take longer. Okay. Well, I mean, anybody would, right? What's another thing, Jennifer? Okay. Cooking. I mean, being able to do, multitask with both hands, that would be difficult. What's another one, Isaiah? It's a big one. Okay. Why is that harder?
Well, especially if you lose your thumb, that's what you use to touch your screen. So
right.
You have to find a different way either.
Okay. So when someone has an amputation, as you guys can see, literally it affects every area of their life, every single aspect, both physically, psychosocially. It becomes a huge burden for the patient until they have learned how to adapt and do things differently. That's why we're here. All right. So what are some psychosocial implications? If what was the cause of the loss of limb? Was it something health related? Was it an accident? Was it something that happened to someone in the military? What was the cause of it? That's going to contribute to the psychosocial factors of it. They may develop, depending on the situation, a PTSD type of diagnosis or something along those lines. Their age, their gender, and their relationship status. Is this somebody that is more of a mature age that can learn to adapt a little bit better maybe? Or is it somebody that even has another person at home to help them learn how to do things again? Depends on which hand or which, that if it was a hand amputation or arm amputation, plays a big role. If you lose your dominant hand versus your non-dominant hand, there's going to be a higher hill to climb. Socioeconomic factors, just meaning like what is available to this person in their area anyway, and insurance and all this other things. There's a lot of factors that go into a prosthetic and how extensive of a prosthetic you can get, because they have some that are just mind-blowing that I'll show you in a little bit, but there are some that are just like a hook, that's very low technology that insurance tends to try to go towards rather than something that is much more beneficial. Takes more training to use, but in the long run is more beneficial. And then culture, values, beliefs, and spirituality. Believe it or not, there are cultures that cutting things off is okay in the culture. I mean, the United States, it's not really a thing, but in other cultures, there are the amputations, and they're higher being told them to cut off their left pinky, and that's seen as normal. And fortunately, I've never came across that. Nobody's ever told me. I have come across patients where, what was the disorder? One of you guys did a presentation on it where, like, they feel like something's not part of their body, and they ask doctors to cut that off. What is that called? Alien hand syndrome. They may act like it's just not, whatever limb is not part of them, and ask them to get it cut off. That's a totally different health issue. Employment status. This is, can the person do their job with their amputation? Is there a reasonable accommodation that we can come up with that will let them continue to do whatever job they were doing? And then lastly is their physical environment. If someone has a lower limb amputation, but they have 50 stairs to get into their front door, that's a higher hill to climb than somebody that's on a single story, one level house with a ramp, right? Now later, they may get to that point, but I'm talking about fresh amputations. What does that impact right off? So some pain and sensory issues. Let's talk about this for a second. Imagine that you guys woke up one morning and feeling like you had a third arm. The arm itched and it felt like there was a vice squeezing your fingers. You knew that you did not have a third arm, but you just could not stop that feeling. Okay? How would that affect school? You'd be distracted. How could you possibly focus if you felt like fingers were in a vice grip and you had a third arm? How could you do that, right? How will that affect driving or your home life or work? Cassie? Right, just kind of seemed like paranoid almost. Yeah, and the biggest thing you guys hit on was the distraction portion of it. You know what? How can you possibly, if your actual hand was in a vice grip and it was being squeezed, how could you do any task throughout the day? Okay. You guys remember last semester where we talked about what phantom limb pain is? What is it? Jennifer, what's phantom limb pain? Okay, when you feel pain in a limb that's not there. So what's the difference between that and phantom limb sensation? Right, it's a feeling that's not there, not pain. It's like phantom limb pain, but without the pain. It's just touch, the sensation part of it. So what are some things that occupational therapy practitioners do to address phantom limb pain or phantom limb sensation? Lindsay, what are some things we do? Rub the nub. Okay. What else would we do? What's that called? You're saying it, but what is that technique called? There's the D. Desensitization. Absolutely. That's one of the biggest things that we can do. What is another area of treatment that we may use for phantom limb pain? Mirror therapy. Absolutely. And I'm gonna show you a really cool video for that too. There's a lot of different things that we can do, but those are the two most common types for sure. So let's talk about any questions so far, or are we good? Good? All right. So let's talk about some types of prosthetics. It's come a long way from like a wooden leg, how they used to do way back in the day. But hooks are a very old type of prosthetic, and we still use those today. In fact, it's one of the most common prosthetics I've ever seen with patients because they're very, they're user-friendly. They don't take a ton of training, and they're cheap, and insurances really, really like them. There are some different types. You have a passive one, which is more or less like a hook. There's not really a ton of movement there. You have body powered, you have myoelectric, and you have hybrid. Body powered means it's like attached, your body's using it. Myoelectric is where it's a prosthetic that uses the electrical signals that are being sent out by your muscles that would normally cause the movement is being sent to the prosthetic and causing movement. Okay. And then a hybrid is like a cross between them. Then you have terminal devices. You may have a cosmetic hand, meaning it's just like a more or less a rubber hand. And that's really for looks. There's not function there. Nothing that's really, worth noting. A hook or something that's activity specific. They have prosthetics that have different attachments, and it may need, for certain things, you have certain attachments. Okay. If you go to page 618 in your book, figure 24.3, there are some different types of prosthetics. Number 5 is a passive prosthetic. Remember, it just kind of looks like a Pretty much just a hand. Number 1 is a myoelectric. That's the one that is using the signals from your muscles, the electrical signals. Number 2 is, it's called an ILM. That's a brand. Your book doesn't really go into what that one is, but just from looking at it, I assume that is a hybrid. It looks like it uses both, but I'm not familiar with that ILM brand. Number 3 is a myoelectric. And then number 4 is that hook I was telling you about. There's a lot of things you can use that for. It doesn't look like it would have a ton of function, but there's a lot you can use it for. To me, it's like a dressing stick. Remember how I told you that, yes, dressing sticks are super helpful, but most patients come up with their own unique ways to use that rather than just the traditional route. That's kind of like a dressing hook on your hand at all times. So let's talk about the prosthetic application. Donning and wearing a prosthetic is not like donning and wearing a glove or a stocking. It is not, it's a procedure that you go through. The different terms here, the pin suspension, I have a picture I'm going to show you in a second, the liner, the shrinker, the socks, and the harness. The one that I want to talk about for a second is the socks. It's not exactly what you think it is. Socks are used to fill the space between the socket and the residual limb, but it doesn't touch the skin. Okay, it's used. Sometimes there can be a gap there, and it just helps keep rubbing from happening. Now I'm going to show you this picture, what this looks like. Okay, so this is where your suspension is up towards the top. Does this look? I wasn't here when Hank was here. Did he have something pretty similar to this? Okay, so here's the suspension part of it, and the socket and the liner. And then down here you'd have the prosthetic foot and ankle and the shin tube. The sock goes in between here and the shrinker. Okay, and I have a video of a guy donning his that we'll watch. It'll make a little bit just to give you a refresher from last time. So how does the type of suspension affect donning and doffing the prosthetic? So the type of suspension, what does that mean? Think back to that picture. It's how it's more or less attached. So how does the different type of suspension affect how you put it on?
I don't remember him having a suspension thing last
Not
time
all
when
of
he
them
was
do.
here, but I assume maybe some of them you need somebody to help you.
Okay, you might need a second person. Okay, it's just an extra step really to keep it a little bit more stable. So let's move to the second one. Why is the shrinker so important, and when would a shrinker be used? Okay, so what is a shrinker doing? This is kind of a review from 209. You're exactly right. It's shrinking that residual limb so it can fit with the prosthetic better. It's helping to shape what it needs to look like in order for the prosthetic to fit correctly. And I already kind of told you what socks are used for, but are socks just for the upper extremity or the lower extremity, or are they for both? It is for both. Absolutely. A lot of people get tripped up on the sock thing, but you can have a sock for the upper extremity as well. Okay, so let's talk about some phases that we go through with prosthetics. The first one is the early management and wound healing phase. The first thing that we're going to be working on here is wound management. There's 2 different types of prosthetics that we're going to be looking at. That's called immediate post-operative prosthetics, or IPOPs, and early post-operative prosthetics, which is EPOPs. These are what you're going to see in the acute care settings, because an IPOP is pretty much right after surgery. This is being done. An EPOP is a prosthetic that's about 5 to 7 days post-surgery. Some other areas we're going to be focusing on is skin care. This is where you're going to be like, hey, watch out for some increased redness, pus, stuff like that for infection, signs of infection. We're going to be focusing a lot on the limb shrinking and shaping and desensitization of the area. Now, not everybody's going to have phantom limb pain. That doesn't happen to everybody, but every amputee is going to have some type of sensitivity afterward. I mean, you cut off a limb or part of a limb, that area is going to be sensitive. So those nerves and things are going to need retrained. Any questions on phase 1? We good? Right. Phase 2, this is the pre-prosthetic program preparation and training. What we're going to start doing here is increasing their general endurance and stamina. The reason that we're going to be doing this in the limb strengthening range of motion is because your body is going to want to compensate for that limb being gone. If you are used to using both of your arms for everything and all of a sudden now you have one arm to use for everything, that one arm is going to get tired way quicker than what you would think because now it's doing the job of both, right? You're going to have them work on ADLs. You're going to have them use the affected and unaffected limbs as much as they can. Use adaptive equipment, education and training, and then the one-handed or cross-dominance training, just meaning, using both. Then you can do what's called myocyte training. This is if somebody can use, if they have been deemed a candidate for a myoelectric prosthesis, which is where, your muscles are shooting those electrical signals. They're going to test to make sure that the signals are strong enough, good enough, that they are a good candidate. This is where that's going to be happening. I personally have never got to do that, and I've always wanted more. You do that a lot more in outpatient settings with people or acute. Some older people with amputations go to skilled nursing facilities and stuff like that, but a lot of the younger people or veterans, they will come back with or they have an amputation and go from acute care, staying there for a little bit, maybe an inpatient rehab for a little bit, and then sent home and go to outpatient if they have transportation. Outpatient is normally where most of your prosthetic training and things are going to be going on. All right, phase 3. What are we going to be doing here? We're going to be teaching them how to don and doff their prosthetic. We're going to be teaching them how to control their prosthetic. You have the body power prosthesis, which is where I told you how it's attached to the muscle. And then you have the myoelectric, which is just the signals are telling it to move. Teaching them how to use that and how to control it. I would be lost if someone came up to me with a myoelectric was like, I need you to show me how to use this. I'm like, I need to talk to my OTR and do this, because that would be, I've never had the opportunity to do that. I wished I could, but who has time right now? Then you have proportional control. This is where, let me back up to that one in just a second, because that's a definition I want to cover for a minute. You're going to teach them their ADLs using their affected limb. And then you're going to teach them how to use their prosthetic with their ADLs. So proportional control, what that means is it's the relationship between the strength of the muscle contraction and the speed or grip force. So it's really trying to hone in the skills to use the hand properly. It's taking the signals and the strength that's sent out from the muscle to the prosthetic and using it accurately. It's not too much, not too little. When I reach out with precision, I can grab this coffee cup and not shove it off the table, that kind of thing. Okay. Are we going phase 3? All right, so phase 4, advanced prosthetic training. This is where you're going to be incorporating the upper extremity prosthetic into all ADLs, work and leisure. You're going to be doing the full shebang, their whole routine with them and using the prosthetic to its maximal potential. You're going to be minimizing comp movements, which is what I was telling how your body wants to compensate for that. If they have an upper extremity prosthetic, you're going to be encouraging them to use that more and quit using their non-dominant hand or their other arm to compensate for it. You want them to use it as if it was normal everyday life. Okay. In phase 4, what you need to remember is that you're moving back to a sense of normalcy. Okay. Life with the prosthetic. Okay. So here's some considerations with prosthetics. They are expensive. They are somewhat fragile, depending on the maker, type, and all that stuff, and can be extremely time consuming to repair them. Depending on which type of repair that the amputee or the prosthetic may require. If it's a hook, maybe you can just order a replacement part, do it yourself. If it's a myoelectric thing, that's way above me. I got to send that to the maker and have that repaired. That's not in our realm. There may be, I've never even looked at, there may be some type of training for OTA practitioners to do that. But to my knowledge, I don't think there is. When you get too high level, it's better to let the people that invented the prosthetic to do it and you be trained on how to use it, not repair it. They also do not function exactly like a normal limb. They've gotten really close with it, and it's getting more and more advanced that some of them you would never even know that it was a prosthetic. They look like a hand. They function like a hand. The movement is a little bit different. It's still kind of robotic type movements, but they've come a really long way from, a hook to that. So when you take into consideration all of these things, bathing, dressing, feeding, sexual activity, grooming, toileting, all this stuff, remember that you're dealing with something that insurances already don't like to pay for, and try your best to teach them safety and how proper care not to break it. Okay, in any ADO or RDO. That's one of the most important things I can teach you with a prosthetic is don't break it. Because normally it's a really long waiting period to get one, and it's even a longer waiting period if you need one repaired or a new one. All insurances are different. Some will pay for replacements sooner than later, but most of the time it's years, long time. If you break it, you're on your own for repair. All right, so some new technology. I'm going to show you a video of mirror therapy and like kind of the history of what prosthetics was and where it's gone to. It's a pretty cool video, but you guys do have, that's it. That's all I'm reviewing for chapter 24 for lecture portion. You guys have a knowledge assessment. And this is going to take some reading from your chapter, okay, and from this video I'm going to show you. List in the following order what is the closest to the skin, the socket, shrinker, and the socks. Just list them in order. And then the last one is list these amputations in order from the longest limb length to the shortest limb length. Oh, no, you guys have a worksheet, don't you? You're right. My bad. Thank you. Nope.
Go right now then?
Sure. My bad. Stop the recording.